and welcome back to Memorable Psychopharmacology. I was at a psychopharmacology conference recently, and the number one request I received was to take the memorable psychopharmacology approach and apply it to drug-drug interactions. So, without further ado, let's dive into the often confusing world of psychotropic drug-drug interactions. At its core, a drug-drug interaction is what happens when one drug has an effect on another drug, often in a negative or unintended way. This generally happens by one of two mechanisms. Either the two drugs have an effect that is too strong in combination, whether that's a beneficial effect or a side effect, or one drug changes the metabolism of another drug. The first type of interaction is seen in something like serotonin syndrome. When a patient is given two different medications that both increase serotonin, the body receives too much serotonergic stimulation and serotonin syndrome can occur. The second type of interaction involves changes in drug metabolism. When a drug enters our bodies, it diffuses through the bloodstream and exerts its intended effects on the target organ, which in the case of psychopharmacology is generally the brain. For the purposes of this lecture, let's say that this drug is sertraline, an SSRI which is commonly used to treat depression. The drug continues to circulate through the bloodstream and exert its effect until it is metabolized by the liver, at which point it is rendered inactive and excreted from the body. Some medications are excreted by the kidneys, but this is rare in psychopharmacology, as we'll find out later. Drug metabolism in the liver is the most common way that one drug can interact with another. For example, let's say that this patient taking sertraline also begins taking a mood stabilizer, in this case carbamazepine. Carbamazepine is a known inducer because it speeds up the metabolism of certain drugs. So for this patient, the metabolism of sertraline will increase, leading to an overall net decrease in the amount of sertraline in their system. In contrast, let's say that this patient taking sertraline instead also begins taking a medication for HIV, such as ritonavir. In contrast to carbamazepine, ritonavir is an inhibitor of hepatic enzyme systems and slows down the metabolism of certain drugs. So for this patient, the metabolism of sertraline will decrease, leading to an overall net increase in the amount of sertraline in their system. This concept is, on the surface, very simple. An inducer will speed up clearance of a drug from the bloodstream, leading to an overall net decrease in drug levels, while an inhibitor will slow down clearance of a drug, resulting in an overall net increase in drug levels. Where it gets complicated is the fact that there's not just a single enzyme system in the liver that is responsible for metabolizing drugs. Rather, there are dozens, each going by seemingly arbitrary and difficult to remember subnames like 2D6, 3A4, 1A2, 2B6, and so on. Each individual drug is metabolized by each of these systems to varying degrees. For example, sertraline is metabolized by the 3A4 enzyme system, whereas another SSRI like fluoxetine is not. If you gave someone a 3A4 inhibitor, the levels of sertraline in the body would go up, while the levels of fluoxetine would not be affected. In contrast, fluoxetine is metabolized by the 2D6 enzyme system, so if you instead gave someone a 2D6 inhibitor, the levels of fluoxetine in the body would go up, while the levels of sertraline would not be affected. A further complication is the fact that certain drugs, known as prodrugs, are actually activated by liver metabolism, rather than being inactivated. For example, the pain medication codeine is converted into its active form morphine in the liver by the 2D6 system. Codeine itself is not a very powerful analgesic, but morphine is. In the presence of a powerful 2D6 inhibitor such as fluoxetine, however, this transformation into morphine is blocked, rendering codeine a very ineffective analgesic. To complicate things even further, the effect that certain drugs have on each enzyme system is not a binary yes or no, on or off type of system. Rather, there is a range of effects that a drug can have. For example, a drug like fluoxetine is a strong 2D6 inhibitor, while sertraline is only a moderate 2D6 inhibitor, and another SSRI, citalopram, is a weak 2D6 inhibitor. Finally, to add that last wrinkle of complication, many enzyme systems in the liver are affected not only by other drugs but by genetics as well. For example, the inherent activity of the 2D6 enzyme responsible for metabolizing fluoxetine is genetically determined. This means that some people are slow metabolizers and operate as if they have a built-in 2D6 inhibitor, leading to increased levels of medications like fluoxetine even at the same dose as somebody else. Other people are inherently rapid metabolizers, leading to lower levels of fluoxetine at the same dose. Putting this all together, the amount of complexity can become almost overwhelming. The different effects inducers and inhibitors can have, the multiple enzyme systems, the distinction between drugs and prodrugs, the strength of interaction, and the contribution from genetics combined can make for a seemingly infinite amount of information to know. Because of this complexity, computerized alert systems have been developed that will let you know when you're about to prescribe two drugs that can interact with one another. While helpful in some ways, given the vast number of possible interactions, these systems are prone to alert fatigue, where the user is warned of so many possible interactions that they just start to ignore all of them. So how can we best address this? We can't completely ignore drug-drug interactions because they have the potential to seriously impact our patients. However, trying to memorize every single interaction is also simply not feasible. To help make sense of this, I recommend an approach where you focus on clinically significant interactions. While this can be a difficult distinction to make between those that are clinically significant and those that aren't, I personally believe that a clinically significant interaction is one where any of the following is true. The interaction is particularly strong, the outcomes of ignoring the interaction are bad, and/or the effect is not subjectively noticeable. We'll go over each of these concepts one by one. As mentioned previously, different drugs can have different effects on enzyme systems. For example, a strong inhibitor like fluoxetine can cause a 5 times or greater increase in the concentration of certain drugs, while a weaker inhibitor like citalopram will not cause any more than a doubling of the concentration. Because of this, we'll focus our discussion on those interactions that are particularly strong. Within the field of psychopharmacology, there are a few particularly strong inducers that you should be aware of. Both carbamazepine and phenobarbital are very strong inducers of the 3A4 system, and you will see them frequently mentioned during this lecture. You can remember these by thinking of them as carb and barb. Conversely, there are a few very strong inhibitors that you should know about. Specifically, bupropion, fluoxetine, and paroxetine are each very strong inhibitors of the 2D6 system, which you can remember by thinking that bupropion, fluoxetine, and paroxetine can cause big freaking problems in drug metabolism, as we'll see soon. Second, we'll focus on the interactions where the outcome is particularly bad if it's ignored. A change in someone's medication for seasonal allergies, for example, can lead to increased allergic symptoms, but is unlikely to result in significant morbidity or death. In contrast, a change in someone's chemotherapy regimen can result in increased chances of cancer recurrence. Finally, we will pay particular attention to those interactions where the effect of our changes are not immediately or subjectively noticeable. Changing the metabolism of someone's benzodiazepines, for example, is often noticeable, and the patient will complain of oversedation or, conversely, of the medication not having any effect at all. In contrast, changing the metabolism of someone's blood pressure medications is not likely to be noticeable by the patient until things progress to the point where a bad outcome, like a stroke, occurs. To remember all the clinically significant interactions that you will run into in the world of psychopharmacology, use the mnemonic, I can have fun heartily outsmarting warring drugs. We'll go over each of these one by one. I is for immune and applies to things like antibiotics and immunosuppressants. Many antibiotics, such as clarithromycin, can also be strong inhibitors of certain enzyme systems. In addition, maintaining appropriate levels of immunosuppressants such as cyclosporine is crucially important for patients with transplanted organs, as too little can cause graft rejection while too much can cause toxicity. Many of these medications are metabolized by the 3A4 system, so carbamazepine and phenobarbital, or carb and barb, can induce 3A4 and cause drastic reductions in immunosuppressant levels. CAN is for cancer, and in particular, breast cancer. Specifically, the medication tamoxifen, given for certain types of breast cancer, is actually a prodrug that must be metabolized by the 2D6 system into its pharmacologically active form. If you are giving your patient a strong 2D6 inhibitor such as bupropion, fluoxetine, or paroxetine, you can prevent the conversion of tamoxifen into its active form, thereby increasing the risk that your patient will experience a recurrence of cancer. This is, as the mnemonic will remind you, a big freaking problem. In addition, many other chemotherapy agents will interact with the enzyme systems in potentially negative ways, so be extra cautious for any patient being actively treated for cancer. HAV is for HIV. Many of the medications used to combat HIV, like the protease inhibitors, are strong 3A4 inhibitors. Therefore, there is a chance that they will interact with the patient's prescribed psychotropics. In particular, benzodiazepines and many antipsychotics will have an increased plasma level for patients taking a protease inhibitor, so you need to be careful to lower their doses to avoid oversedation and extrapyramidal side effects. FUN is for fungal medications. Many antifungal agents, such as fluconazole, are strong 3A4 inhibitors and, like the protease inhibitors, can increase the effect of certain benzos and antipsychotics. Heartily is for heart conditions. Several classes of medications that are used to treat heart conditions, including arrhythmias, such as lidocaine, and certain beta blockers, such as carvedilol and metoprolol, are metabolized by the 2D6 system, so their levels can raise drastically in the presence of a strong 2D6 inhibitor such as bupropion, fluoxetine, or paroxetine. Sudden changes in these medications can lead to arrhythmias, hypotension, and cardiogenic shock, so, like with tamoxifen, this can be a big freaking problem. OUT is for oral contraceptives. Specifically, you must be mindful to avoid certain medications for patients taking oral contraceptives to avoid inducing their metabolism and rendering the contraception ineffective. For example, patients prescribed CARB or BARB should not be taking an oral contraceptive and will need to seek alternative methods of contraception. SMARTing is for seizures. Many anti-epileptics, including but not limited to those used as mood stabilizers for bipolar disorder, have significant drug-drug interactions. For patients taking an anti-epileptic, you need to be careful not to give them an inducer, which could lower the seizure threshold and possibly provoke another seizure. One drug-drug interaction involving anti-epileptics that deserves special mention is between valproate and lamotrigine. These medications are both used as mood stabilizers, but given that valproate works for mania and lamotrigine works for depression, it is not at all uncommon to see these being combined. Valproate is not the strongest inhibitor, but has enough of an effect that when it is combined with lamotrigine, the plasma levels of lamotrigine are often significantly higher. Given that the major side effect of lamotrigine, Stevens-Johnson syndrome, is directly related to the dose and frequency of lamotrigine, this actually becomes crucially important. To avoid an unnecessary increase in the risk of Stevens-Johnson syndrome, make sure to use half the dose of lamotrigine you normally would, and consider titrating the dose half as fast. You can remember this by thinking of Valhalla, the majestic hall located in the afterlife of Norse mythology. By thinking of Valhalla, you can remember that when you use valproate, you should use half the dose of lamotrigine to avoid killing your patient and sending them to Valhalla. Next, warring is for warfarin and other anticoagulants. Warfarin is metabolized by various enzyme systems in the liver. Given the narrow therapeutic window for warfarin being effective rather than toxic, this can result in clinically significant interactions between inducers like CARB and BARB, which can lead to a subtherapeutic INR, and inhibitors like valproate and disulfiram, which can increase INR and cause pathological bleeding. Warfarin is not the only anticoagulant subject to drug-drug interactions, as other anticoagulants such as rivaroxaban can be affected by CARB and BARB as well. Finally, there's a theoretical risk that SSRIs and other blockers of serotonin reuptake could interfere with platelet function, as platelets cannot synthesize serotonin and instead rely on reuptake to use it for clotting. However, this risk appears to be more theoretical than actual, and most of the evidence that any interaction exists is anecdotal. Finally, drugs is for diabetes. Many of the medications used for diabetes, and particularly the secretagogues like linagliptin, are metabolized by the 3A4 system, so our old friends CARB and BARB can return to mess things up here as well. On a practical level, you can use the I Can Have Fun Heartily Outsmarting Warring Drugs mnemonic as a quick screen when reviewing your patient's problem list and medication regimen. If they have any of these conditions or are taking medications related to them, be extra mindful to look for drug interactions from any medication you start. So you've done your due diligence for your patient by making sure that they're not on any of these high-risk medications. However, you still have the sense that you're missing something. That's because you might be. Besides the medications we prescribe, there are many substances that our patients take without our knowledge or consent that can wreak havoc with drug metabolism as well. So when you have a nagging worry you've forgotten something despite having checked the medication list, consider counseling your patients on the following substances. N is for nicotine. Tobacco use results in induction of the 1A2 system, which is responsible for metabolizing many of the drugs we use commonly in psychiatry, including antidepressants and antipsychotics. Given that up to 70% of people with schizophrenia in the United States smoke frequently, this is something to be aware of, as sudden changes in smoking habits, such as quitting smoking, can cause levels of antipsychotics to fluctuate wildly. Interestingly, it's not the nicotine per se that induces the enzymes, but the aromatic hydrocarbons in tobacco smoke. So a patient switching from cigarettes to nicotine replacement may experience a major shift in the levels of their psychotropic medications. A is for alcohol. Alcohol acts as an inhibitor of several enzyme systems in the liver when used on an acute basis. However, chronic alcohol use actually causes liver damage, which acts as an inducer of enzyme systems. G is for grapefruit juice. Grapefruit juice is a commonly available 3A4 inhibitor, like carbon barb. However, just because it can be picked up off of any grocery store counter does not mean that it's benign. Grapefruit juice-related drug interactions include many of the medications that we use in psychiatry, including antidepressants, antipsychotics, benzodiazepines, stimulants, and mood stabilizers. WUR is for St. John's wort. St. John's wort is a dietary supplement which is available without a prescription for use as an antidepressant. However, it is also a strong inducer of 3A4 and can interact with all of the conditions mentioned in the I Can Have Fun, Heartily Outsmarting Warring Drugs mnemonic. So remember to use the mnemonic nagging worry when you're concerned about non-prescribed drug-drug interactions. To wrap up, we're going to go over a few last high-yield tips to help you tie psychotropic drug-drug interactions together. First, as mentioned earlier, nearly all the interactions we have discussed so far have to do with enzyme systems in the liver. This is because virtually all the medications used in psychiatry are hepatically metabolized. The only real exceptions to this are gabapentin, acamprosate, and lithium, all of which are renally metabolized. You can remember this by thinking that the kidneys filter gal drugs just like they do a gallon of water. In particular with lithium, you need to make sure to avoid other medications that could damage the kidneys and lead to lithium toxicity, though this topic was covered in more detail in the section on lithium. Another point of review is that benzodiazepines, like most psychotropics, are metabolized by the liver, so they should be avoided for patients with hepatic dysfunction. However, 3 benzodiazepines are safe to give even with a diseased liver, and these are oxazepam, temazepam, and lorazepam. The classic mnemonic for this is to remember that they are metabolized outside the liver. However, this mnemonic isn't exactly accurate, as oxazepam, temazepam, and lorazepam are all metabolized in the liver. The difference is that they are metabolized by conjugation, meaning that they don't have active metabolites. This means that their half-lives are the same as always, even in advanced liver disease. So if you're going to use the outside the liver mnemonic, and it is very handy, please also remember that on a scientific level it's not 100% accurate. Finally, these drug-drug interactions involving psychotropics have been covered in more depth in their respective lectures. Make sure to review them if they're rusty. Serotonin syndrome is reviewed in the lecture on neurotransmitters, hypertensive crisis is covered under antidepressants, and the QTC prolonging medications like citalopram and ziprasidone are in their respective sections. And now a final take-home point. While we've covered some of the major drug-drug interactions to be aware of, there's simply no way to cover them all. In addition, your patients will have genetic differences in enzyme systems that will further complicate things even if they're not taking any other drugs. In psychopharmacology, it's important to be mindful of these variations and to always try to find the minimum effective dose. Because we are titrating to an effect rather than a specific dose or plasma level for most of our medications, it's wise to always start at a lower dose range and increase only when it's clear that the current dose is not doing the job. So remember to start low and go slow. A quick overview of what we've learned. Within psychopharmacology, carbamazepine and phenobarbital, or carbon-barb, are the major inducers, while bupropion, fluoxetine, and paroxetine are the major inhibitors, causing big freaking problems. You can remember the medical conditions and medication classes most often responsible for significant drug-drug interactions with psychotropics using the mnemonic, "I can have fun heartily outsmarting warring drugs," with the additional nagging worry mnemonic to recall non-prescription drug interactions. Nearly all psychotropics are hepatically metabolized except for the GAL drugs, gabapentin, acamprosate, and lithium, which are renally excreted just like a gallon of water. Finally, the OTL benzos, oxazepam, temazepam, and lorazepam, are practically excreted outside the liver and are safe to use in patients with hepatic failure. Thanks for watching this episode of Memorable Psychopharmacology. I'm excited to announce the release of the book version of Memorable Psychopharmacology last month, so click on the link to our website to learn more about that. Thanks again for watching. Best of luck with your studies.